Guys, and welcome back to my channel. Today we will study on how to read and interpret a ECG, right? On what all various things we can learn from an ECG, how we can study it and how is it clinically important to us. So first of all we will start with how to calculate the heart rate, right? So what happens is, if there is 1, 2, 3, 4 divisions and the ECG runs like this and it's continuing. So what do? Is we take two R intervals, right? So if this is P, Q, R, R, so the distance between these two is R interval, right? R interval. So we call this R interval. So the distance between the two R intervals, right? That will give us the number of heartbeats. Suppose if we take it in the paper as 300, the distance between these two peaks is 300 and we take 1 and 2, right? As I told you, the ECG box, which is 5 by 5, so every fifth box is dark. So 300 divided by 2, that will be what? 150 BPM. So that is how we calculate the heart rate from an ECG paper, right? So heart rate is very simple. The distance between the two RR intervals is the heart rate. Next, let's see various steps on how to read an ECG. So initially the step 1 will be definitely you will ask for the patient's history, if he has had a history of cardiac problems or he's taking certain drugs like digoxin digitalis or various other cardiac glycosides or even ecosprin for that matter, like blood thinning agents. We have to check for the PTINR, the from international normalizing ratio, and various other criteria, which is also the age of the patient, because if the patient is pediatric, right, definitely their heart rate is higher compared to an adult where the heart rate is low. You can't say that this is pathological or this is physiological or vice versa. So we need to take the history of the patient and on what drugs he is, whether he's taking a stimulant or a depressant, and then we can conclude if the patient is normal, he comes for an ECG. So what do we start with first? So first we check the technical and quality calibration. So we have to check if the paper is running at 25 or 50 mm per second, right? The paper speed. So again there are two criteria. If the patient is normal, then we take the speed of the paper as 25 millimeter per second. But if the patient has tachycardia, then we increase the speed of the paper to 50 mm, right? We can increase the speed, it is adjustable. Next is calibration. So we have to check if the calibration is exactly at 10 mm, like I told you in my previous video. Each small box represents 1, right? So if the if it is exactly at 10 mm per millivolt, we have to check for those, right? So once this is done, then what do? Is we go to the next step, that is we check for the rates. So slow, normal and fast. So in medical term, how do we call this? Bradycardia, normal sinus, tachycardia. So what is bradycardia? When the heartbeat is less than 60 beats per minute, then we call this as bradycardia. If it is a normal sinus, anything between 60 to 100 beats per minute, and if it's tachycardia, greater than 100 beats per minute. So now let's see what is a normal sinus rhythm. So if you see a wave of an ECG, P, Q, R, ST, and the wave goes on, right? So if the wave is going, if it is taking a definite area in a definite time, then we call it as a normal sinus, right? Where the beat comes as 60 to 100 beats per minute. So in a normal sinus or a regular sinus, what can we detect? Either the heart rate is regular or there is sinus arrhythmia. So what are the criteria for it? If the P wave is negative in the augmented vector right of the right arm, right? Augmented lead of the right arm, or we have a positive in second, third lead and augmented V of the foot, right? Augmented V of the foot. Then we can see various conditions. So what happens is, if there is any issue with the P wave, then what do we detect? If it is negative in the L1, then what can we see? There is either dextrocardia, that is the heart is located on the other side, and there is dextrocardia. In case if the P wave is negative in the right arm lead, right, the right arm lead, so what happens over here is the arm lead reversal has taken place. Arm lead reversal has taken place. PQRST wave is seen negative in lead 1, right? When we check the lead 1, we see P, Q, R, S and T waves as negative if the entire P wave is coming as negative, because there is a reversal, because there is always a charge difference. If one is positive, one is negative, the other one is positive. That is how we separate it. So if this is reversed, then again there is a difference in polarity and there is some problem. And if the P wave is not applied, then there is some issue with the L2, right? We have to keep checking on to the L2. What is the issue over there? So with this, we have completed the basic step of taking the history of the patient. Then we check if the calibrations are correct, right? If the paper is moving at a definite speed and various other criteria, and about the heartbeat. Now let's go to the rhythmic diagnosis, right? How is the rhythm and what are the problems, right? So regular or irregular rhythms, right? So this is atrial fibrillation and atrial flutter. So AFIB and AFL, right? So atrial fibrillation and atrial flutter, please do remember it. So if there is regular or irregular, so if the rhythm is irregular, then we can diagnose an atrial fibrillation, right? Atrial fibrillation. I will explain it to you in the coming videos. What is atrial fibrillation? What is atrial flutter? But for now, just remember, if it is irregular, then there is atrial fibrillation, and there is atrial flutter if there is occasionally it is irregular. If there is occasional irregularity, then that is sometimes if the beats is irregular, then we can say it's an atrial flutter. Next, if the P wave is present or absent, right? Present or absent. So based on that, we can tell many things. Or if the QRS is narrow or wide, and rate of P and QR relation, right? So there is always a relation between the P wave and the Q wave, right? So if P is equal to QRS, or P is greater than QRS, or P is less than QRS, right? So there are three criteria. So now let's come to the rhythm. As we discussed, especially we'll focus on the P wave, right? So again I told you, if the rhythm is slow, we call it as bradycardia. So what can be the causes of bradycardia? Sinus bradycardia, right? Or escape rhythm, or an AV block, right? AV block. So how do we treat AV block? We use a drug called dobutamine, which is specially works on the dopaminergic receptors, and it prevents AV block without hampering the heart rate. Please do remember this, the dobutamine drug doesn't hamper the heart rate. Next, if the P wave is present, then it is a normal sinus, because a P wave is present in a normal ECG. Next is, if the P wave is absent, then it can be a flutter or a fibrillation, which I told you. Regular or irregular, that decides the criteria whether the flutter is or whether it is a flutter or a fibrillation. Next is tachycardia. So what can be the causes? Sinus tachycardia, supraventricular tachycardia, and ventricular tachycardia. Due to these reasons, and also one more thing to take in mind, sometimes it can be physiological. If the patient has run or he has done an intense physical activity, then if you check the ECG and tell that no, the patient has got a tachycardia, then we cannot tell that the patient actually has a tachycardia. It is physiological, right? So this is done in a condition where the patient is in a state of rest, where the arm lead and the foot leads are attached, and then we do it. And also when we are counting for the we do it when the patient is at rest, in simple words. Next, so these are the first three steps. I hope you have understood. Now let's go to step 4. So we determine the QRS axis in frontal plane, right? So I'll show you what the plane is. So we use this plane to determine the left and the right axis deviation. Very helpful. So if you see this is the heart, right? This is the heart. So what happens is we divide it into axes. So minus 90 and plus 90, 180, 0 degrees, 150, 30, and there are various other values, right? So negative 150 represents augmented vector lead of the right arm, right? Negative 30 indicates augmented vector lead of the left arm, right? Next is 120 degrees, which indicates lead number 3. Then there is 60 degrees, which indicates lead 2, and 90 degrees, which indicates augmented vector lead of the foot. So 1, 2, 3, 4, 5. So we have 5 leads over here. So this is the heart, this is the axis, and there is a circle. If you imagine it in a circle, I haven't drawn the circle, but if you imagine it in a circle, then you can definitely have a look at this. So what does this tell? If L1 is positive, L3 is positive, then the axis is, what is the axis? What is the normal axis, which is negative 30 to plus 90 degrees. Negative 30 negative 30 is over here and plus 90 here. This is the normal axis, right? This is the normal axis. There is no deviation. Now, if the lead 1 is positive, lead 3 is negative, but lead 2 is negative. The lead 2 is negative, then we see a left axis deviation. So this shifts towards the left side, right? The whole thing shifts towards the left side. So the deviation is called as a left axis deviation. Next is, if the L1 is positive, L2 is negative, but L3 is negative, and L2 is equiphasic. That is, the R and the S complex, right? The R and the S complex are in the same phase. So what do we see? We see an axis of negative 30. So we can see an axis of negative 30 over here. This is negative 30. Next, again L1 positive, L3 positive, but L2 is also positive. L3 negative and L2 is positive. So again this is a normal axis. So we have a normal axis of negative 30 plus 90. We have a normal axis if L1 positive, L3 negative, and L2 is also positive. Next, if L1 is positive, L1 is negative, L3 is positive, we see a right deviation, that is from plus 90 to plus 180 degrees. So plus 90 to plus 180 degrees, right? This is plus 180, this is plus 90. So plus 90 to plus 180. So this is the right deviation. This is moving towards the right side. So right deviation, this is the left deviation. We can see it in the ECG, right? If there's a right deviation or a left deviation, but you should know this table with the values. Next, if L1 is positive, L1 is negative, L3 is also negative. So what do we see here? We are not considering the L2 here. We're just considering if L1 and L3 are at a given time, there is negative value. So there is right superior, or we call it in simple words as no man's land, that is minus 90 to minus 180 degrees. So minus 90 would be here and minus 180 would be somewhere here. So that is how we give the various values of the axis. And now we will go about the PR complex and we will see how we check for those, right? So guys, let's continue now to step 4a. So what do we do is we measure the PR interval over here, right? The distance between the P and the R complex, that is the PR interval. So what happens is, again, there can be three conditions. It can be slow, the duration of the PR interval specifically, not the rate of the heart. The PR interval can be slow, normal, or prolonged. So if it is slow, then what is the criteria? It is less than 0.12 seconds. So what happens over here is WPW or atrial rhythm is reduced. I will explain what is WPW later. Next is upper AV junctional rhythm. We can see an upper atrioventricular junctional rhythm, or a normal variant, which can be of another type of AV rhythm, right? So it can be a normal variant of another AV rhythm. Next, if it is normal and it is 0.12 to 0.20 seconds, then there is no issues. Definitely it's normal. Next, it is prolonged, but what happens over here is with preserved AV conduction. It's prolonged, but preserved AV conduction is taking place. Definitely the conduction is taking place. So greater than 0.20 seconds. So either there is a no drop beat in the atrioventricular beat, or there is a drop in the beats and there is no AV conduction. There is no conduction taking place from the AV side or the AV node, right? There is no conduction taking place over there if the PR interval is prolonged. Next is QRS complex duration, and after this we'll study about the QRS complex voltage. This is more interesting, the voltage part, so I'll explain it to you. So what happens over here is we measure the QRS complex duration. The normal duration is 0.10, less than that, right? So what happens is if it is normal, no issues. If it is equal to or more than 0.1 up to 0.12 seconds, then what happens is we can consider an BBB, right? BBB, or bundle branch block. We don't know if it is left or right, but you can just consider there is a BBB. Next, there is intraventricular construction disorder. There is a malformation in the heart, right? Malformation in the heart. Next, if it is wide, greater than 0.12 seconds. If the rhythm is in sinus, right? If the rhythm is in sinus first, if it is in normal sinus, then we can consider a left bundle branch block or a right bundle branch block. Or if there is no sinus rhythm, then we can see a ventricular rhythm. If there is no sinus rhythm, then we observe a ventricular rhythm. So where can we find this exactly? So you have to look at lead number V1, V6 and 1. Lead number V1, V6 and 1, that is where we can detect if there is a widening of the QRS complex. Now we'll study about the voltage. Right, what is the voltage of the QRS? This will be a bit lengthy, but it is interesting again at the same time, right? So coming to step 4C, so what do we do is we measure the QRS voltage. So again, if there is a voltage can either be high or low, right? So if there is a high voltage, then how we see? So SV1 plus RV6, S in V1 and R in V6, that's what it means, is greater than 35 mm, right? The amplitude is greater than 35 mm. R in lead 1 is greater than 15 mm, or R in augmented vector lead of left side, right, is great. R is greater than augmented vector lead is greater than 11 millimeter, right? So if the R wave is greater than this, so again, what do we suspect over here? We suspect a LVH, or a left ventricular hypertrophy. Hypertrophy is the increase in size without the increase in number of cells, and hyperplasia is increase in size because of the increase in number of cells. So we have a hypertrophy and not a hyperplasia. Please do not confuse. So what can we exclude over here? So we have suspected the patient has an LVH, or left ventricular hypertrophy, but there are certain conditions. Ventricular pacing. So if there is ventricular pacing, that is, you have to look for pacemakers, artificial pacemakers. If the patient has an artificial pacemaker, then definitely these criteria are fulfilled, but the patient doesn't have an LVH or left ventricular hypertrophy. Hyperkalemia, we have to check for the blood potassium level. If the potassium level is greater in the blood, then we can again suspect that 154, 155 plus if the levels are deciliter, in deciliter, right? So then again we can suspect that there is a LVH, but if there is hyperkalemia, there is a prolonged QRS complex. So that can confirm that there is hyperkalemia. So again we rule out left ventricular hypertrophy, and we also look for delta wave, WPW. It is related to Parkinson's, right? It's related to Parkinson's. Now the physiological causes, I'll tell you. So absence of LVH on ECG. No, the absence of LVH. So if we are looking on the ECG paper, and if we don't suspect an LVH, then definitely the patient doesn't have a left ventricular hypertrophy, but only diagnosed if seen in the ECG paper. If it is seen in the ECG paper, we have to exclude these criteria. Even after that, we suspect there is a left ventricular hypertrophy, then definitely our patient has a left ventricular hypertrophy. Next is the physiological causes. Athletes and young people show tall QRS voltages. They have a tall QRS voltages, but there is no LVS. This is physiological, not pathological. So we rule out again the left ventricular hypertrophy. Now, if the amplitude is low, so what is happening over here is QRS complex in limb lead is less than 5 mm or 10 mm in precordial lead, right? In the precordial lead. So what happens is, if there is these values less than 5 mm and 10 mm, so what do we see? We suspect a pericardial effusion. So there is a triad for it, that is why I have drawn this triangle. It is accompanied by this triad. If there is a pericardial effusion, we get to definitely see these three things: low voltage, tachycardia, and electrical alternateness. So gold standard symbols to identify a pericardial effusion. Next, we can also suspect a pleural effusion, that is the pleural fluid is coming out from the pleural cavity. Again, pericardial fluid is coming out from the pericardial cavity, right? Or the pericardium to be specific. Emphysema, that is swelling of the lungs, increase in size of the lungs, due to which again this can happen. This happens in COPD. What is COPD? Chronic obstructive pulmonary disorders, right? It contains a large number of groups. So there are two types. One is obstructive and destructive. In one case, the patient is not able to breathe in, and there is obstruction, right, to breathe in, and then there is restrictive, that is he is not able to breathe out. We can discuss that when we discuss about the lungs. We can also suspect a pneumothorax, or in cases of obesity also this can be seen. Next, previous massive myocardial infarction. If the patient has had a previous and a very severe myocardial infarction, then definitely we can have again a low amplitude because of the drugs, right? Because of the drugs the patient is taking, so we have to reduce the heart rate over here. Next is hypothyroidism. Hypothyroidism, less thyroid, less metabolism, less heart rate, right? Simple. End stage dilated cardiomyopathy. So he can have a cardiomyopathy in the end stages, like it is in the finishing stages. Or infiltrative myocardial disease. What is an infiltrative myocardial disease? Simple. A tumor that is infiltrative, right? It infiltrates the myocardium, so it is a tumor. Next, what do we see here? That is We go to stage number 5 now, stage 5A, right? So this is a very long stage now. So we will discuss about various stuff over here. So what is the thing we are seeing first is we look at the R wave. So R wave is whether it is normal or it is slow, or basically we look at the progression of the R wave, right, in the precordial leads. So this is how a normal R wave progresses. So there is a parabola over here and it goes normally, and again it is going up forming a parabola, and this is how till V6 it goes. I have drawn only till V5. So this is how a normal R wave is progressing. But if there is a slow R wave, so this is how it progresses. So you can clearly see the difference, right? You can clearly see the difference. So this is slow progression of the R wave. So this is what are the causes now. So if the R wave is like this in the ECG, then what is the exact cause? Why is the, so this is the R wave here, this is the R wave here, right? For you to not get confused, V1, V2, V3, V4, V5, V6. As we go, it further gets short, right? Over here it has to get wide, but here it is becoming short, right? In between, yes, definitely it's getting wide. So what are the causes? Anterior myocardial infarction. Anterior myocardial infarction. Next is incorrect lead placement. Incorrect lead placement, and more chances in obese people. If there is obese people, there is more chance of this to occur, specifically women. This is not being sexist or something, but yes, this is the disease. Especially in obese women also this can be seen. And incorrect lead placement and obesity also, specifically in obese women. Left ventricular hypertrophy, LBBB, left bundle branch block, and in case of Parkinson. Next is dextrocardia, the heart is placed on the other side. Tension pneumothorax, the pneumothorax which is caused due to some stress with mediastinal shift. So if we look at the chest x-ray, so we can tell if the mediastinum has shifted or not. There are certain criteria, like you might know it, A, B, C, D, E, so airways, bone, and various other criteria keep going, right? So you have to check these criteria: diaphragm, effusion, and the costophrenic angle. So we have many ways to read in chest x-ray, and it is very useful also. I will teach it to you definitely someday, but for now let's focus with mediastinal shift, right? Next is a congenital heart disorder. In such cases we can see a slow progression of the R wave. So now let's look at the step 5B. So what we do is we look at the R wave progression in precordial leads, right? So previously we saw the R waves, now specifically the precordial leads. So what happens is abnormal R wave in V1, right? In V1 progressively decreases in amplitude. As it progresses, the amplitude decreases. So we'll study all the P waves. So it is best seen in lead 2 and V1, right? Lead 2 and V1. So in lead 2 it is less than or equal to 0.12 seconds and greater than 2.5 mm, right? Sorry, less than 2.5 mm, that is the amplitude and this is the time. And V1 it is biphasic, right? So here are 3 different types of P waves along with the diagram. So if the P wave is too wide in 2 and V1, right, we are comparing both. So if it is too wide, we suspect a left atrial abnormality. So what is happening is in L2 it is greater than or equal to 0.12 seconds and it is notched. And prominently negative terminal force in V1, right? It is prominent negative in terminal force V1. It is negative over here. As you can see, it is negative over here. Next, if the P wave is too tall, we suspect a right atrial abnormality. Right atrial abnormality, what is happening is P wave is too tall, peaked in L2. It is peaked over here. P is greater than 2.5 mm in indifferentiated lead, that is L2, and greater than 1.5 mm in amplitude in V1. Now, P wave is negative in indifferentiated lead, that is 2, 3 and augmented vector lead of the foot. So what do we suspect over here? Retrograde P wave and ectopic beat. And the next one is a funny P wave, as the name suggests, because of the shape. It is called as a funny P wave. And the same thing is seen in an ectopic beat again, which is suspected. Now let's come to T wave. Normal. It is normal when it has same polarity as QRS deflection. Upright in 1, 2, V3 to V6, right? If it is upright in V1, 2, V3 and V6, always inverted in augmented vector lead of right arm. It is always inverted. So if we see these type of P waves, this is called as an hyperacute P wave, seen in 5 to 30 minutes after the onset of the myocardial infarction. It has a broad base and it is round in summation. This is a hyperkalemic T wave we get to see when there is hyperkalemia. So it is best seen in the precordial leads, narrow base, and it is tenting. It is narrow base and tenting. Now here are a few this thing abnormal T waves. And yes, one more thing, inversion in V1 to V3 in children and adolescents. There is always inversion in V1 to V3 in children and adolescents, right? For adults it's always in AVR. So abnormal T waves, right? So this is inverted, biphasic, flattened, and camel hump. There's a camel hump here. So this shows severe hypokalemia, prominent U wave, and fused T wave. And over here this is a hidden P wave. We cannot see a P wave, it is fused with the T. So what is happening is embedded with the T wave. We don't get to see a P wave here. Sinus tachycardia, and in cases of heart block. So let's come to step 8. So what we'll discuss here is the ST segment. So the normal duration of the ST segment is 0.08 seconds. It is flat, it is isoelectric, and should be in level with the PR and the TP segment, right? It should be in level with the TR and the TP segment. So the ventricle remains depolarized over here, obviously. Difficult to determine where the ST ends and the T begins. It's difficult because they are too close to each other, right? So it's very difficult to determine. So therefore, relation between the ST and the T determines together. So we have to determine the relationship between the ST and the T together to diagnose various diseases. So most common cause of an ST abnormality, which is either elevation or depression, is a myocardial infarction or an ischemia. So it helps to diagnose acute myocardial infarction and ischemia, right? So if there is ST depression, what happens is it is ischemic. Most commonly it is ischemic, right? Ischemic heart injury takes place over here due to lack of blood supply. So what happens over here is the subendocardial infarction. The cases which can cause here is subendocardial infarction and reciprocal changes in association to the acute myocardial infarction. So the changes which is associated with the acute myocardial infarction, or also drug effect. I will explain you. So this is the ECG wave for ischemic or for early myocardial infarction. This is also called as a scooping ST segment. Scooping ST segment. This is in digitalis effect, or the reverse tick sign, right? When there is digitalis toxicity. Next is the elevation. This is in acute myocardial infarction. So convenes the ST elevation, right? Convenes the ST elevation. Convex. I'm sorry. There is a convex. So this is concave. So this is convex. So we see a convex, like you can see over here, convex ST elevation. Transmural ischemia, ventricular aneurysm. Elevation doesn't subside after the acute myocardial infarction, and in case of pericarditis. So as I told you, convex. So this is convex in acute myocardial infarction, and this is for pericarditis. This is the various ST segment waves. Now we will study about the ST elevation in myocardial infarction, which is also called as STEMI. So we have almost come to the end of the lecture with the last part, that is ST elevation in myocardial infarction, or STEMI. So how do we diagnose it in the ECG? So limb lead ST elevation is the value there will be 1 mm, right, or 1 millivolt greater than, or in the pericardial it will be 2 mm or 2 millivolt. Elevation must be present in anatomically contagious leads. I will explain you what does that mean. So if it is inferior, it is in 2, 3 and tegmental vector lead of the foot. If it is lateral, it's in lead number 1, tegmental vector lead of the left arm, V5 and V6. If it is septal, it is in V1 and V2. If it is anterior, it is V3 and V4. So STEMI in various positions, we can see it in such leads. So approximation of infarction size can be assumed with the ST elevation. So if the ST elevation is more wide, then definitely the infarction is of a great danger. But if it is less, then again it is less severe comparatively, respectively. So over 90% of males have 0.1 millivolt of ST elevation in any one precordial lead. So in any one precordial leads, there will be a slight ST elevation. You don't have to always diagnose it as myocardial infarction. It is there in 90% of males. So you look for a reciprocal change of ST depression in lead opposite to the area of injury. So I will explain it to you. What does that mean? So example, in case of acute transmural inferior in ischemia, so the direction of the ST elevation faces injury side, right? So if there's a ST elevation, it is facing to the side of the injury, which is here in the heart. But cause of the elevation is in 2, 3 and AVF. So 2, 3 and AVF, there is an ST elevation, while the tail of the ST vector is faces the anatomically opposite side where the ST depression is caused. So the tail, right, the tails of the vector is facing where the ST depression is caused. That is in the aggumental vector lead of the limb, that is of the left arm, sorry, and in lead number 1. So over here and over here you can see a depression, whereas there is clear elevation seen over here, and this was the site of the injuries, right? So in the opposite side, clearly you can see 3, 2 and AVF corresponds to the injury, and over here AVL and 1 is in the opposite side anatomically. So if the ischemic injury, this is the site of the ischemic injury in the heart, anatomically opposite side, there will be a depression in the ST, right? So there is a depression in the ST complex. So this is what I was trying to explain with the example over here, this statement over here, right? Now the STEMI can be present with concave elevation also. As I showed you in the previous ECG, there was a concave ST, right? But the fact that the ST elevation is just upward concave doesn't mean it is an STEMI. It can be a ischemia also. We have to look further carefully for other causes in the other leads, whether it is ischemia or it is an STEMI. Just a concave shape of the ST segment doesn't confirm that it is an STEMI. So with this, I hope you guys can now diagnose and interpret how to read an ECG, and I've tried to simplify it as far as possible. And if you do like the video, then do give a thumbs up, and thanks for watching, and do subscribe to my channel for more such useful content. Till then, thank you.